Welcome to a very special PRISM Rounds edition of our deep dive.
Yes, welcome everyone.
If you're tuning in, you probably already know that PRISM stands for Pulmonary, Critical Care, and Sleep Medicine. And today, we are basically bringing the intensive care unit directly to your headphones.
Straight to you.
Think of this as teaching rounds. And you, listening right now, you are the vital third member of our medical team today.
That's right.
Now, I'll be taking on the role of the practical ICU attending, the one focusing on the workflow, the resource allocation, and what actually happens when those alarms are just going off constantly and we have a crashing patient right in front of us.
And I am stepping into the role of the evidence-focused ICU fellow. The clinical researcher, I'm the one bringing the giant stack of journal articles to the nurse's station, ready to really tear into the trial design, the appendices, the stats, and the objective data.
We're thrilled to have you on the team for rounds today.
Definitely.
But before we get into the thick of this clinical scenario, we do have a required disclaimer to share with you.
Right. Very important.
Please note that this is an AI-voiced educational discussion. It is designed for medical professionals, trainees, and our FOMED listeners. It is absolutely not medical advice.
Prefer.
Always consult your local protocols and, of course, your own clinical judgment.
Absolutely.
All right, let's set the clinical scene for you, because we really want to ground this entire discussion in bedside reality.
Put us right there.
Picture this. It is 2 a.m. in the intensive care unit.
Witching hour.
Exactly. The unit is humming. The IV pumps are beeping incessantly down the hall. You know that sound. And you have a critically ill patient in bed 4.
Okay, bed 4.
Let's say it's a 65-year-old male presenting with profound septic shock secondary to a perforated viscus.
Very sick.
Extremely. You have been pushing liters of crystalloid fluids over the last 12 hours. You've got norepinephrine and vasopressin running at high doses. And that's just to maintain a mean arterial pressure that's, well, compatible with life.
Just barely holding on.
Right. So you pull up his latest morning lab pulse, and his serum albumin level is deeply in the red. It is sitting at 2.2 grams per deciliter.
Ouch.
Yeah. And the temptation, the absolute burning psychological temptation at 2 a.m. is to order a few of those glass bottles from the blood bank and just fix that number.
It's so hard to resist.
It really is. So the clinical question we are exploring in this deep dive is this. In a patient with septic shock, if we actively replace that albumin to keep the serum level at or above 3.0 grams per deciliter, does that actually improve their 90-day survival?
And that is the exact bedside dilemma tackled by the paper we are dissecting today.
Let's hear it.
We are pulling this directly from the JAMA Network Open, published in February 2026. The article is titled Albumin Replacement Therapy in Septic Shock, a Randomized Clinical Trial.
Great paper.
It really is. Specifically, we're going to be evaluating the ARISS trial.
ARISS. Got it.
And for the rest of our discussion today, we'll just naturally refer to it as the ARISS trial.
Perfect. Now, I always appreciate getting the bottom line up front before we start, debating confidence intervals and inclusion criteria. What are the definitive spoilers for the ARISS trial?
The short answer for you is this. The protocolized albumin replacement strategy looked remarkably safe.
Okay, safe is good.
But it did not improve 90-day survival.
Ah, there it is.
However, there's a massive caveat that fundamentally alters how we interpret the data. Because the trial was stopped early due to low enrollment, the results are best classified as an inconclusive negative, rather than a definitive closed case against albumin.
Wow. A classic critical care trial outcome.
Sure.
The headline feels negative, but the nuance is where the real medicine actually happens.
Exactly.
Let's unpack this and figure out what it means for a patient in bed for tomorrow morning.
Let's do it.
To really appreciate what the ARISS investigators were attempting to do, I think we have to look at the messy middle of sepsis pathophysiology and the absolute, decades-long controversy that surrounds albumin in the ICU.
It's a controversy that just refuses to die.
It really does.
Largely because of the sheer divide between biologic plausibility and demonstrated outcome benefit.
Right.
Biologically, giving albumin to a depleted septic patient makes perfect sense. We know that albumin is responsible for roughly 75 to 80% of the normal oncotic pressure in healthy plasma.
Sure.
But the physiologic rationale goes far beyond just holding fluid in the vessels.
And I think that's the trap we fall into on rounds all the time.
Oh, constantly.
We hyper-focus on the oncotic pressure. We look at the patient in bed 4. His endothelial glycocalyx is completely shredded by the systemic inflammatory response.
Just destroyed.
Right. That inner lining of the blood vessels has become incredibly leaky. It's essentially turned into a sieve. So we are pouring in endless oceans of Ringer's lactate or plasmolite, and a huge portion of it just third spaces right out into the interstitial tissues.
It just doesn't stay in the pipes.
Exactly. He's getting anasarca, his lungs are getting wet with ARDS, his bowels are edematous, leading to a massive ILIS. And the classic, almost mythological teaching is that if you give a large negatively charged protein like albumin, it stays in the intravascular space, it plugs the holes.
Right.
And it holds that fluid inside the pipes where it can actually generate a blood pressure.
Which is such a compelling narrative.
Yeah.
But the molecular mechanisms are even more seductive than that.
Tell me more.
Well, albumin acts as a primary transport molecule in the bloodstream. It actively binds to drugs, endogenous toxins, and bacterial products.
So it's kind of a scavenger.
Exactly. Furthermore, it possesses significant antioxidant properties. There's this single free cysteine residue on the albumin molecule, Cy34, and it acts as a major scavenger for the flood of reactive oxygen species.
And those free radicals are actively destroying tissues during severe sepsis.
Precisely. On top of that, it has recognized anti-inflammatory effects and modulates nitric oxide availability.
Which is huge.
It is. Because nitric oxide is a key driver of the refractory vasodilation we see in distributive shock.
It makes so much physiological sense that it is almost painful when it consistently fails to translate perfectly in major clinical trials.
It's the story of critical care.
We face this cognitive dissonance all the time. You're staring at the monitor, you're drinking that terrible stale break room coffee, you're watching the patient's lactate climb and their blood pressure drop.
And you just want to do something.
Right. The human brain loves an actionable metric. You think, the albumin is low. I will give albumin. The number will normalize, the oncotic pressure will stabilize, and the patient will survive.
If only it were that simple.
But the reality of critical care medicine is much harsher. We cannot confuse biologic plausibility with demonstrated outcome benefit.
That is the key phrase.
Just because a substance theoretically should mitigate a systemic infection on a microscopic level does not mean it translates to more patients actually surviving to day 90.
The history of fluid resuscitation trials in the ICU perfectly illustrates that point.
It really does.
The ARISS trial didn't just emerge in a vacuum. It was designed as a direct response to a very specific historical lineage of fluid research. Specifically, the shift away from synthetic colloids and the lingering questions left by previous albumin trials.
Well, we have certainly been arguing about this for a long time. I remember the era when we were aggressively pushing hydroxyethyl starches, the synthetic colloids.
Oh, yeah, the starches.
The biologic plausibility was there, they expanded the plasma volume beautifully, but then the major trials hit and showed they were causing acute kidney injury. They were increasing the need for renal replacement therapy and actually increasing mortality in sepsis.
A total disaster.
So we abandoned starches, which funneled the debate strictly into crystalloids versus human serum albumin. We had the landmark SAFE trial, which looked at saline versus albumin for broad ICU fluid resuscitation.
Right, safe.
It found them to be largely comparable overall, though it showed a potential signal for harm in traumatic brain injury, and a tantalizing, though unproven, signal for benefit in severe sepsis.
Which brings us to the Italian ALBIOS study.
Yes, the immediate predecessor that truly set the stage for ARISS.
The ALBIOS trial is the necessary prologue here. Funded by the Italian Medicines Agency, it was a massive undertaking that enrolled 1,810 patients with severe sepsis and septic shock.
That's a huge trial.
It was. Their intervention was remarkably similar to what we are discussing today. The administration of 20% albumin to maintain a serum concentration of at least 3.0 grams per deciliter.
And as I recall, the overarching results of ALBIOS were negative.
They were.
When looking at the entire cohort of 1,810 patients, there was no significant 28-day or 90-day survival benefit for the albumin group.
None.
But, as happens so often in these massive trials, the investigators dug into the data after the fact, and they found a specific subgroup that generated a massive hypothesis.
Precisely. The post-hoc subgroup analysis of ALBIOS focused specifically on the 1,121 patients who presented with actual septic shock.
Meaning those requiring vasopressors.
Right, rather than just severe sepsis. In that specific subgroup, the 90-day mortality was significantly lower in the albumin group. It was 43.6% compared to 49% in the standard crystalloid group.
That's a big jump.
It yielded a p-value of 0.03. Furthermore, the ALBIOS data suggested a trend where the survival benefit appeared most pronounced if the albumin therapy was initiated specifically between 6 and 24 hours after the onset of sepsis, rather than immediately in the acute resuscitation phase.
Now, you and I both know the inherent dangers of post hoc analyses.
Oh, they can be treacherous.
They're brilliant hypothesis generators, but they are incredibly dangerous if you use them to change clinical practice directly.
Absolutely.
If you take a massive data set of a heterogeneous syndrome like sepsis and you slice it up into enough subgroups, you will inevitably find a statistically significant result purely by chance.
Just math.
So the ARISS trial was built entirely to test that post-hoc signal from ALBIOS in a rigorous prospective manner.
They wanted to prove it.
They essentially said, let's take patients exclusively in septic shock. Let's wait out that initial 6-hour chaotic resuscitation window, and then actively target a serum albumin of 3.0 for the next 28 days to see if that survival benefit is real.
And that is exactly what they did. The ARISS study design is a prospective, multi-center, open-label, interventional, randomized clinical trial.
Okay.
It is a phase 3B trial conducted across multiple intensive care units.
The multi-center aspect is crucial for external validity, especially given how wildly fluid resuscitation practices and resuscitation targets vary from hospital to hospital.
They really do vary.
But I want to pause on the open-label designation. In an ideal world, we want double-blinded, placebo-controlled trials.
Of course.
However, in fluid resuscitation trials involving albumin, blinding is notoriously difficult and profoundly expensive. You just can't easily disguise a thick, foaming, yellowish glass bottle of 20% albumin to look like a plastic bag of normal saline.
No, the nurses know immediately.
Exactly. So the clinicians at the bedside knew exactly who was getting the albumin protocol and who was getting standard crystalloid therapy.
The open-label nature is a limitation we must keep in mind, especially regarding secondary interventions. If a clinician knows the patient is in the albumin arm, it might unconsciously influence their decisions regarding diuretic use or other volume management strategies.
That's a great point.
But moving to the inclusion criteria, the investigators were exceptionally strict about identifying the right phenotype. They enrolled adults within 24 hours of the onset of septic shock.
Within 24 hours. Okay.
And they adhered to the updated Sepsis 3 consensus definitions, requiring a clinically possible, probable, or microbiologically confirmed infection.
I am really glad they used the strict Sepsis 3 criteria. To qualify for ARISS, these patients had to have a lactate strictly over 2.0 millimoles per liter.
Right.
And they had to require vasopressors to maintain a mean arterial pressure of 65 millimeters of mercury or higher, specifically despite adequate initial volume therapy.
That's the key, despite adequate volume.
Which rules out the patients who are just transiently hypotensive from dehydration.
Exactly.
The patient in our bed 4 scenario fits this perfectly. He has had his initial 30 cc per kilo bolus, but his lactate is still 3.5, and he is maxed out on Levophed just to hold an MAP of 65. These are the patients hovering on the brink of refractory multi-organ failure.
They are incredibly sick. Once a patient met those stringent criteria, they were randomized. If assigned to the intervention group, the protocol dictated the administration of 20% human serum albumin, starting precisely within that 6 to 24-hour window after shock onset.
And the intervention itself is staggering when you think about the bedside logistics.
That's massive.
This wasn't a single 500 cc fluid challenge of albumin just to assess fluid responsiveness.
No, not at all.
The goal was to aggressively titrate the albumin to maintain a serum concentration of 3.0 grams per deciliter, or 30 grams per liter, or higher, continuously, for up to 28 days while the patient remained in the ICU.
The duration and intensity of the intervention really cannot be overstated. It required daily laboratory monitoring of serum albumin levels. If the morning lab pull showed the level had dipped to 2.8 or 2.9, the clinical team was mandated to hang more 20% albumin to drive the number back above the threshold.
Translating that to the workflow of an ICU, it is an immense commitment of nursing time, pharmacy resources, and healthcare dollars.
Very expensive.
Human serum albumin is a pooled blood product. It is a scarce resource subject to shortages, and the pharmacoeconomics are significant. We are talking about thousands of dollars per patient just to chase a specific number on a lab sheet for a month.
And the control group.
What did they get?
The control arm was straightforward. They received standard fluid therapy, volume replacement exclusively with crystalloids, adhering to standard local practices and surviving sepsis campaign guidelines, but strictly avoiding the routine or protocolized use of albumin.
With an intervention this demanding and expensive, the expected benefit has to be massive to justify the practice change.
It does.
That brings us to the power calculation. When we look at the methodology, how many patients did they calculate they needed to prove this strategy actually saves lives?
The statistical modeling here is key. The investigators estimated a baseline 90-day mortality rate of roughly 50% in the standard care control group.
Which is a realistic expectation for refractory septic shock.
Very realistic.
Yeah.
They powered the trial to detect a 15% relative reduction in mortality. In absolute terms, that means they were attempting to prove a 7.5% absolute reduction, dropping the mortality rate from 50% down to 42.5%.
A 7.5% absolute reduction in mortality for a sepsis intervention is incredibly ambitious.
It's huge.
If we found a single intervention that definitively saves 7 or 8 more lives out of every 100 septic shock patients, it would rewrite the global guidelines immediately. But to prove a difference that specific, especially against the chaotic background noise of an intensive care unit where patients are dying of secondary ventilator-associated pneumonias or multi-organ failure, you need a massive sample size.
You do. To detect that 7.5% difference with 80% statistical power and factoring in an anticipated 15% dropout or protocol deviation rate, the investigators determined they needed to randomize a total of 1,662 patients.
Wow.
That would give them roughly 831 patients in each arm to evaluate.
So the stage is set. We have a biologically plausible intervention, a hypothesis built directly from the ALBIO subgroup data, and a mathematically rigorous trial design seeking 1,662 patients.
Yep.
What happened when they actually tried to execute this across multiple centers?
They ran straight into the brutal reality of critical care research.
Let me guess.
The trial did not reach 1,662 patients. It was prematurely terminated due to low enrollment.
How many did they get?
Over the course of the study period, they only managed to randomize 440 patients.
440 out of a planned 1,600.
Not even close.
That is a staggering shortfall. But honestly, as an attending who has tried to enroll patients in these types of trials, I am not surprised at all.
So difficult.
Let's discuss why this happens. Because the screening logs for these trials are often more illuminating than the final results themselves.
I agree.
You were trying to capture patients within a very specific 6 to 24-hour window of septic shock. This is arguably the most chaotic, frightening phase of a patient's hospitalization.
The logistical hurdles are immense. First, you have the strict inclusion criteria. Then you have the exclusion criteria. If the patient has a moribund condition with a life expectancy of less than 28 days, they're out.
Right.
If there's already a do not resuscitate order or an end-of-life care trajectory established, they are out. If they have severe decompensated congestive heart failure where massive albumin loads might trigger acute pulmonary edema, they're excluded.
And then you have the human element of obtaining informed consent.
Which is the hardest part.
At 2 a.m., our patient in bed 4 is intubated. He's deeply sedated on propofol and fentanyl, and he's fighting for his life. You have to find a family member or a healthcare proxy who is currently experiencing the most traumatic day of their life.
Right.
You have to sit them down, explain the concept of clinical equipoise, explain a complex randomized trial involving blood products and daily lab protocols, and ask them to sign a dense legal document.
It's overwhelming.
It is incredibly daunting for the families, and it is massively time-consuming for the research coordinators who are trying to operate in a high-stress environment. Furthermore, running a multi-center trial during a period where ICU resources were stretched thin globally, combined with competing sepsis trials at the same institutions, it just makes enrollment a nightmare.
It really does.
Yeah.
So the investigators ultimately had to make the difficult decision to stop the trial early.
Sad, but necessary.
So we are left with a final cohort of 440 randomized patients. 222 were assigned to the targeted albumin protocol, and 218 were assigned to standard crystalloid therapy.
Pretty evenly split.
Yes. And despite the early termination, the baseline characteristics of the enrolled patients were well balanced. The median age was roughly 69 years, about 66% were male, and the baseline SOFA scores indicating the severity of organ dysfunction were comparable between the two groups.
Okay, let's look at the primary outcome. They committed immense resources to maintain that 3.0 target in those 222 patients.
You did.
What was the actual impact on 90-day all-cause mortality?
Here are the numbers. In the intervention group receiving the 28-day targeted albumin protocol, the 90-day mortality was 43.3%.
Oh, okay.
In the control group receiving standard care, the 90-day mortality was 45.9%.
I saw those numbers in the abstract, and at first glance, a 2.6% absolute difference, 43.3% versus 45.9%, it looks like a slight edge for albumin.
It does look like a slight edge.
It feels like maybe, just maybe, it's doing something beneficial. But when you apply the statistical rigor, the confidence intervals tell a completely different story, don't they?
They absolutely do. The relative risk was calculated at 0.94. But the 95% confidence interval is massive, ranging from 0.76 all the way to 1.17.
Right.
Because that confidence interval crosses 1.0, the finding is not statistically significant. The p-value for the primary outcome was 0.71.
Which means we can translate this plainly for our listeners' clinical practice. The results are numerically different, statistically unconvincing.
Exactly.
A p-value of 0.71 indicates that the 2.6% difference we are seeing could incredibly easily be nothing more than random statistical noise.
Just chance.
It is well within the normal variation you would expect if you just flipped a coin. The trial completely failed to demonstrate a survival benefit from this intensive albumin replacement strategy.
The lack of a primary outcome benefit naturally forces us to scrutinize the secondary endpoints.
We always look for a silver lining.
Right. Even in trials where the 90-day mortality is negative, we often look for signals in secondary metrics, like organ failure resolution or ICU length of stay, just to understand the physiological impact of the intervention and guide future research.
Right. Looking at the supplementary appendix for ARISS, they tracked a comprehensive battery of secondary metrics.
They really did.
Did the targeted albumin strategy help the patients get off the ventilator faster? Did it lead to a more rapid resolution of shock, meaning more vasopressor-free days? Did it reduce the total amount of fluid administered?
They meticulously tracked all of those metrics. They looked at earlier mortality time points, specifically 28-day and 60-day mortality. They tracked daily SOFA scores to map organ dysfunction. They measured ICU and hospital lengths of stay, ventilator-free days, and vasopressor-free days.
And did any of those secondary metrics show a statistically significant benefit?
The data tells a very consistent story across the board. If we look at the earlier mortality time points, the raw numbers might initially catch your eye.
Okay.
At 28 days, the mortality was 31.0% in the albumin group, compared to 38.1% in the control group.
Yeah.
At 60 days, it was 38.9% in the albumin group versus 45.2% in the control group.
A 31% versus 38% mortality rate at 28 days. That's a 7% absolute difference.
It is.
When you are standing at the bedside of our patient in bed 4, a 7% potential improvement in survival at the 1-month mark feels incredibly significant. It is exactly the kind of number that makes clinicians want to keep ordering the albumin.
It absolutely feels significant anecdotally,
No.
but scientifically, we are bound by the math.
Always.
Absolute. None of those secondary mortality differences reach statistical significance.
None of them.
None. The confidence intervals for the 28-day and 60-day time points still cross the null effect line. Furthermore, when the investigators analyzed the resolution of organ failure via the SOFA scores, there were no significant differences.
So no faster recovery.
Right. The patients in the albumin group did not spend significantly fewer days on the mechanical ventilator, and they did not experience a statistically significant increase in vasopressor-free days compared to the standard care group.
So the intensive protocol did not definitively improve survival, and it did not reliably accelerate the resolution of shock or respiratory failure.
That's the summary.
This brings us to perhaps the most crucial bedside question. Grounded in the first rule of medicine, primum non nocere. First, do no harm.
The safety profile.
Right. I see this argument all the time on rounds. A clinician will say, sure, the survival data is a wash, but look at the patient's anasarca. If I aggressively push 30 grams of protein a day in a neuric septic patient, am I going to throw them into acute decompensated heart failure?
It's a valid concern.
How closely were the investigators actually monitoring for pulmonary edema and harm?
The safety monitoring was rigorous, and the safety profile is actually the most reassuring piece of data to emerge from this trial.
Okay, good.
The protocol mandated active vigilance for substance-specific adverse reactions, like severe allergic reactions, urticaria, or anaphylactic shock, which are always a risk with pooled human plasma products.
Definitely, yeah.
More importantly, for our critical care concerns, they actively monitored for signs of hypervolemia and pulmonary edema.
Because that is the physiological
Yeah.
trade-off, right?
Yeah.
You give high concentration 20% albumin, specifically because it is hyperoncotic. It pulls interstitial fluid back into the intravascular space. But if the patient's right ventricle is already struggling against high pulmonary vascular resistance from ARDS, or if they have underlying diastolic dysfunction, pulling liters of fluid back into the pipes can rapidly overwhelm the heart, leading to acute pulmonary edema.
That is the fear. But the data did not show a harm signal.
That's reassuring.
The incidence of adverse events, or AEs, was remarkably similar between the two cohorts. In the targeted albumin group, 54.5% of patients experienced an adverse event. In the standard care control group, it was 48.1%.
Very close.
The investigators concluded that there were no major significant differences in the frequency or severity of adverse events, including fluid overload or pulmonary edema. The intensive albumin therapy, as implemented by this specific study protocol, did not appear to cause excessive harm.
This highlights a critical teaching pearl for you listening right now. We need to make the distinction crystal clear in clinical research. Negative for benefit is not the same thing as harmful.
That's so important to remember.
Sometimes we read a negative trial like ARISS, and the immediate reflex is to say, oh, albumin is bad in sepsis, I should never order it again. But that is a misinterpretation of the data.
Completely.
Albumin appeared reasonably safe in this specific setting. If you give it, you are probably not poisoning the patient or directly causing iatrogenic pulmonary edema. You just aren't mathematically proving that you are saving their life with a protocolized target-chasing strategy.
Which leads us perfectly into the major limitation of the ARISS trial, and why interpreting this specific pacer requires so much nuance.
Well, lay it on me.
We have to discuss the concept of the inconclusive negative and the profound impact of being underpowered.
I think this is vital, because I can already hear the debates happening in the residency lounges. Someone is going to point to that 31% versus 38% mortality rate at 28 days and argue if they had just managed to enroll the full 1,600 patients, that 7% difference would have easily reached statistical significance.
Right.
And this trial would be considered a massive win for albumin.
And mathematically, they might be right.
That's the frustrating part.
If we revisit the power calculation, we see exactly why this trial is so frustrating to interpret. The investigators needed 1,662 patients to clearly separate the true effect of the intervention from the chaotic statistical noise of intensive care outcomes.
But they didn't get them.
No, because they only recruited 440 patients, the study is severely underpowered.
Let's contextualize what an underpowered trial actually means for our bedside decision-making.
Let's do it.
When a trial is severely underpowered due to low enrollment, it dramatically increases the risk of a type 2 error, a false negative. We usually talk about p-values and type I errors, which is finding a difference that isn't really there. But a type 2 error means that the treatment actually does work in reality. Perhaps targeted albumin truly does save 3 or 4 extra lives per 100 patients treated.
But you can't prove it.
Exactly. Because your sample size was so small, the mathematical formulas simply cannot confirm it with confidence. The signal is buried under the noise.
That is the exact dilemma we face here. The ARISS trial yielded a non-significant p-value, but we cannot definitively say whether that is because the albumin strategy genuinely lacks efficacy, or whether the albumin strategy is highly efficacious, but the 440-patient cohort was simply too small to prove it.
It leaves us in limbo.
It does. The authors are very transparent about this in their manuscript. They state explicitly in their conclusion, as this trial was prematurely terminated, results remain inconclusive, and additional studies are recommended.
So we absolutely cannot walk away from this deep dive declaring that albumin is definitively useless in septic shock.
No, we can't.
We have to explicitly treat this result as an inconclusive negative. It adds to the body of literature, but it is not the definitive final answer on fluid resuscitation that we were hoping for.
Which is undeniably frustrating for clinicians who want clear, binary guidelines. But it is the honest, scientific reality of the evidence we currently have.
It is what it is.
So let's bring this all together. Let's do the clinical translation. Tomorrow morning, you're leading rounds, and you're standing outside the room of our patient in bed 4.
Okay, I'm there.
He is still on multiple pressors, his lactate is elevated, and his serum albumin is 2.2. Based on everything we have dissected from the ARISS trial, what are the practical, actionable bedside takeaways?
This is where we synthesize the data into clinical practice.
Yes.
Takeaway number 1. This trial does not support routine albumin replacement simply to chase an albumin lab target of 3.0 grams per deciliter in septic shock.
Don't just treat the number.
Right. If your specific hospital unit has a standing protocol that automatically triggers the pharmacy to send up an albumin infusion every time the morning lab value drops below 3.0, ARISS tells us that specific protocol is not backed by definitive mortality data. It is immensely expensive, it is highly labor-intensive for the nursing staff, and it did not clearly save lives in this cohort.
Takeaway number 2 focuses squarely on the safety profile we discussed. Albumin appears safe in this clinical setting.
Safe, but not proven to improve survival.
Exactly. The intensive study protocol of maintaining levels above 30 grams per liter for nearly a month did not lead to increased rates of pulmonary edema, allergic reactions, or other severe adverse events compared to standard crystalloid care. If your clinical judgment dictates giving albumin, you likely aren't actively harming the patient.
And takeaway number 3, nuance and individualized medicine remain paramount.
Always.
Some clinicians may still use albumin selectively for individualized hemodynamics. For example, if the patient in bed 4 has received 8 liters of crystalloid, he's profoundly volume overloaded with massive third spacing, yet his intravascular volume appears completely depleted based on point-of-care ultrasound or stroke volume variation.
You see that all the time.
You need to pull some of that interstitial fluid back into the vessels to get the vasopressor requirements down. In that highly specific, personalized physiological scenario, you might still logically reach for a 20% albumin infusion. But the ARISS study completely fails to justify a broad, one-size-fits-all, protocolized strategy applied blindly to every septic shock patient.
I want to push on that clinical nuance a bit more.
Go for it.
Given the results of SAGE, the overall negative results of ALBIOS, and now the inconclusive negative of ARISS,
Yeah.
why do you think the critical care community still clings to albumin so tightly? It is still ordered constantly in ICUs worldwide, despite the lack of broad survival benefit.
It is a phenomenal question, and I believe it comes down to the profound psychology of practicing critical care.
Psychology over data.
Sometimes, yes. As an attending, I experience it constantly. When you have a young patient dying of refractory shock, you feel a deep, visceral helplessness. You have an overwhelming urge to do something.
Or anything.
Crystalloids are cheap, but we know they leak. And you physically watch the patient swell up over the course of your shift. Albumin feels like a premium, physiologically sound intervention. And fundamentally, we are all trained from medical school to fix abnormalities.
Find a problem, fix a problem.
When we see a red, low number on an electronic health record, our deepest reflex is to normalize it. But we have to constantly remind ourselves and our trainees of the critical difference between fixing a low lab number and changing meaningful patient outcomes.
That's a huge distinction.
I can order enough albumin to make our patient's lab chart look absolutely perfect tomorrow morning. But if he still passes away from multi-organ failure at day 90, I haven't actually practiced effective medicine. I've just treated the computer screen.
That perfectly encapsulates the core debate. Cost and resource allocation versus uncertain outcome. Physiology versus evidence-based medicine. It requires immense clinical discipline to step back at 2 a.m. and ask, am I treating the underlying pathophysiology of the patient, or am I just treating the electronic health record?
Exactly. So, to give you some concrete phrases you can use to defend your practice on rounds tomorrow, I want you to remember these exact teaching pearls.
Write these down.
If a consultant asks why you aren't aggressively replacing the albumin in a septic patient, you can confidently state, the data shows it is safe but not proven to improve survival.
Safe, but not proven to improve survival. Got it.
When someone argues that we absolutely must give it to preserve oncotic pressure and protect endothelial glycocalyx health based on textbook physiology, you say we cannot confuse biologic plausibility with demonstrated outcome benefit.
Don't confuse biologic plausibility with demonstrated outcome benefit.
And when an enthusiastic resident suggests starting a 28-day replacement protocol to normalize the labs, you remind them gently, routine target chasing is not the same thing as thoughtful, individualized care.
Routine target chasing is not the same thing as thoughtful, individualized care.
Yeah.
Those are fantastic summaries that cut right to the core of the evidence.
Thanks. Can you give us the final summary?
To provide a clean, concise wrap-up of the ARISS trial itself, The strategy of administering 20% human serum albumin to aggressively maintain a serum level of 3.0 grams per deciliter or higher did not statistically improve 90-day survival in adult patients presenting with septic shock.
Right.
Reassuringly, there was no major safety signal, meaning the intervention did not cause excessive harm or fluid overload compared to standard care. However, the early termination of the trial due to low enrollment severely limits our certainty.
The inconclusive negative.
Exactly. Because the study was significantly underpowered, the result must be interpreted as an inconclusive negative, meaning routine, protocolized use of albumin simply to chase a target lab number remains unsupported by the current robust data.
As we wrap up this deep dive, I want to leave you with a final provocative thought to mull over on your own as you digest this literature. It builds on the frustrations we've discussed today, but looks toward the future of critical care research.
I'm listening.
We keep designing these massive, multi-million-dollar trials, treating septic shock as if it is one single monolithic disease entity.
Which it isn't.
Sepsis is a wildly heterogeneous syndrome. A patient with gram-negative urosepsis behaves completely differently than a patient with gram-positive pneumonia. If we stop trying to force every single septic patient into strict, protocolized lab targets, how do we better identify the specific phenotype of a septic shock patient who actually derives a massive survival benefit from albumin?
The holy grail of sepsis research.
Is there a specific genetic marker or a novel biomarker of severe endothelial glycocalyx degradation that will eventually tell us exactly who needs the expensive protein infusions and who just needs standard crystalloid fluids?
Precision medicine.
Is the future of ICU fluid resuscitation moving entirely toward personalized precision medicine rather than relying on these broad, one-size-fits-all clinical trials that keep resulting in inconclusive negatives? It is a paradigm shift that the entire critical care community is going to have to wrestle with in the coming decade.
It is a fascinating question, and one that highlights precisely why we need to keep analyzing the evidence, even the inconclusive evidence, with such rigor. We have to understand where the general protocols fail in order to build the personalized therapies of tomorrow.
Well said. Thank you so much for joining us as the vital third member of the team on this PRISM Rounds edition of our deep dive.
Thanks for having me, and thanks for listening.
We hope you feel a little more armed, a little more skeptical, and ready for the intensive care unit tomorrow. Keep questioning the evidence at the bedside, keep focusing on the patient in the bed rather than the numbers on the monitor, and we will see you next time.